Okay, good morning, everybody, and welcome. On behalf of the Chester County Economic Development Council and our industry partnership, Healthcare Connect, we want to thank you for joining us this morning. We have a very important, very timely topic, and we're excited to be bringing this to you this morning. We've got some excellent panelists that are lined up and with us this morning, and I know have some great insights and perspectives to share with you. So before we do that, I did want to take just a minute or two to tell you about the Chester County Economic Development Council. Excuse me. I'm sure many of you obviously are familiar with Healthcare Connect, but you may not know what CCEDC does, as we call ourselves, CCEDC. And there may be some areas that we could be helpful to other areas of your business, or perhaps a friend or a colleague that we can help as well. So I'll just take a minute or two to just give you some quick highlights of what we do, and then we'll get on with our program. If I could advance the slides here, that would be helpful. There we go. So again, my name is Mike Brigalonis. I serve as the Chief Operating Officer here at the Economic Development Council. I've been here for about 22 years now and proud to be so. Our mission and vision are really very simple. There's a lot of words on your screen here, but it really boils down to private sector job growth, and that's growing businesses. And while we're doing that, we're creating jobs and hopefully contributing to the overall prosperity of Chester County and really the whole region. But what's key to that is while we're doing that, while we're growing businesses, we're also very respectful and very cognizant of the quality of life we enjoy. So we're always trying to strike that balance to make sure that we're growing businesses, but yet still preserving that open space in the county and the wonderful schools that we have and the trails and everything else that goes into making Chester County such a special place to live. Just some real quick basics. We were established back in 1960, so we've been at it for quite a long time, over 60 years. We are private, nonprofit. We work very closely with our county staff, the commissioners themselves, but we are a private nonprofit organization. And so the model in Chester County for as long as I've been around is to have a public-private economic development service delivery, and it's worked real well. We have a board of directors who's very active, an executive committee that meets with us on a regular basis to help guide and steer our activities. We've got an operating budget of around $3 million. And a staff of 31, 23 of which are full-time. And then we have a few contractors and a few part-time folks as well. But it's a very dedicated and a staff that I'm proud to be associated with. And you can see all of their smiling faces on your screen there this morning. So really just our services, we do a lot of different things, and sometimes they seem unrelated, but we try to organize them under four major categories. The first one is financing solutions and providing access to capital for the companies in our county and our region that are growing. We're busier now probably than any time we've ever been, perhaps in the history of our organization. The activity is probably, our pipeline is 2.5 or 3 times what it normally would be. And I would think some of you probably find that surprising, given that we're hopefully at the tail end of a global pandemic. But I can tell you that in our SBA world, for example, we're doing 3 times the volume that we do in a normal year. So it's a good sign, I think, on many levels. But our programs are primarily for fixed asset financing. So you're buying equipment, you're buying real estate, you're expanding your building, those types of things. Sometimes we can do refinance as well. But our real core sweet spot is when we can do that fixed asset financing. So it's long-term fixed rates. Right now it's 2.75% fixed for 20 years. So very attractive. So if we can ever be helpful in that area, please do give us a call. Location services is really the real estate side of what we do. And, that ranges from helping companies to make sure they have the right site or the right building to accommodate their growth. But it's also working in communities and perhaps working with developers to help them make their projects successful. 2 examples that I would cite to you are, one, working very closely with Pennhurst up in the northern part of our county, the former state hospital, and trying to redevelop that into a job producing site with some commercial components to it. So we're making some good progress there. And then we're also working down at Cheney University with Mosaic Development Partners as they reimagine the campus of Cheney. They're looking to invite businesses to be part of that campus and locate on those campus and interact with the students. And we're very involved in trying to market that opportunity to businesses. And there's lots and lots of good opportunities in the keep an eye on Cheney University's campus. I think you're going to see some exciting things there. Workforce development, we have a lot of time and energy invested into making sure that our county maintains having the world-class workforce that it does. One of the reasons Chester County has been so successful from an economic development standpoint is because our workforce is really top notch. And we spend a lot of time trying to continue to maintain and nurture that workforce, whether it's working with our young folks. Many of you are probably familiar with our healthcare academies, some of the showcases we've done in the healthcare arena as well. So we're really active working with our youth, not just in healthcare in many industries, but certainly very active in the healthcare world. We also are very aggressive in pursuing training grants, so we can then award those grants to local companies that are looking to upgrade the skills of their incumbent workers, all the way up to dislocated workers as well, trying to connect those dislocated workers, those job seekers, with our employers who are looking to hire. And we're active in lots of different events, and that just recently a number of job fairs actually targeted to residents of the city of Coatesville that have been very, very successful, new models with transportation involved. So always looking to do new things to try to connect our employers with our job seekers. And then lastly, our innovation culture, working with our emerging tech companies. We have a program called I2N, Ideas Times Innovation Network. And the idea there is just as the name suggests, the culture. So all those things that allow an entrepreneur to thrive, whether that's peer-to-peer learning and networking opportunities where they can learn from each other, providing them access to venture capital or angel networks, helping to make sure maybe co-marketing spaces that are available for collaboration, whether they be co-location or co-working spaces or incubators, whatever they may be. And those types of things to try to develop, it's sort of an intangible, but that culture that we know is so important for entrepreneurs, especially tech entrepreneurs, to thrive. So lastly, just giving you a sense for the types of people we work with. And as you can see, it's a very wide group, a lot of different stakeholders, certainly the businesses themselves, whether they be existing businesses in the county. A lot of times we're working with companies that are outside the county, even international, who might be thinking about investing in Chester County. We are active in there trying to make sure they understand the merits of why one would want to grow in Chester County. But we also work closely with our educational institutions, our high schools, our Chester County Intermediate Unit, our universities and colleges, very active with them, especially obviously in the areas of workforce development. And of course, our county government and all of our local municipalities, helping them in many cases to identify and market key strategic sites that they might want to see growth happen at as well. So that's a quick overview. Again, if we can ever be helpful, that's why we're here. We exist to help companies grow and organizations be successful. So please don't hesitate to give us a call. So with that, I'm going to transition to really the leader of our Healthcare Connect program, and who's going to kick us off this morning is Dr. Claire Mooney. Dr. Mooney serves as the president and the CEO of Jennersville and Brandywine Hospitals for Tower Health. As I say, she's also the chair of Healthcare Connect. So Claire, over to you.
Thank you, Mike. I want to give a warm welcome to everyone attending our spring forum, COVID-19 Impacts on Healthcare Workers and PA as a Trauma-Informed State. As many of you know, Healthcare Connect, an industry partner of the Chester County Economic Development Council, is in collaboration with employers in the public and private sector. Our focus is 4 main priorities: behavioral health access, priority number 2, training, our priority number 3, transportation, and priority number 4, Healthcare Connect partnership sustainability. As we know, many of you here today, we want to thank those who are in attendance. So first, I want to give a shout out and a welcome to the intermediate unit students at Souderton. And I also want to thank Flo Byarms, our Healthcare Connect Behavioral Health Action Team Champion and the manager of Community Health and Equity Paoli Hospital Mainline Health. She is bringing to us our first presenter, Bill Belamonte. He is the manager of the Paoli Emergency Department and the only trauma center in our county. So warm welcome to Bill. Before I have him start, I do want to let everyone know that if you could, in the welcome part where your name is, if you could also include your organization, and we would like to put all of the questions in the question and answer. So not through the chat that many of you may be used to utilizing, but there is a Q&A tab at the ribbon bottom of your screen. If you could do that throughout the event, I will be compiling those questions and answers to ask our panelists at the end. So thank you, and turning it over to you, Bill.
Thank you. Let me just share my screen here to make sure you guys can see my slides, and I'll get going shortly. What I'll say, and you mentioned flow, we are very fortunate here at Paoli to have flow. Every organization needs a flow. Not only is she the manager of community health and equity, but when we think of the challenges that we all faced with COVID, our community outreach was somewhat less as we internalized our focus to be able to meet the needs of our community. And Flo's role was no exception to someone that was asked for change. She's done a great job carrying the weight of making sure that those arriving on our campus are appropriately screened and assisted with wayfinding as they arrive to our campus kind of in this COVID, post-COVID state. So I imagine you guys can see my slides by now. I think it's important to mention before I begin that this is the story of one team. There are many different teams that in healthcare or any other industries were impacted by COVID. This is one department in one hospital. If we stepped beyond the emergency department, say into a critical care environment, the air felt much thicker when they're facing the most critical of COVID patients. So I can't say that the experience that I'll share with you is the same for everyone, but I'll tell you that it's the experience from my perspective in this team. One thing that I'll say is you look at this picture and what is the change? Well, we're kind of close to each other. We're not wearing masks. You'll see that many of my female counterparts have their hair nice and relaxed. Ironically, this picture was taken, tomorrow will be 1 year since. And we weren't told as essential workers that masks were required until that first week of May. So just looking back, it's crazy to see where we are today from where we were then. Just a little bit about me, a tale of two people there in those pictures. The first thing I'll say is I'm a resident or a native of Chester County. I'm a graduate of the Coatesville Area School District. I graduated from West Chester University. And what I tell many people here at Paoli, my dad is one of 14 kids that grew up 1.5 miles from this hospital. So chances are you're a friend of my family, whether or not you know it, because I have a pretty large family. You'll see a disclosure statement at the bottom, probably fitting for a presentation that, I won't be selling you a product here. But the bigger thing is, I'll tell you, is about me. You'll see on the left where it talks about somewhat of my private life. You'll see that there's nurse listed there. You'll see that there's 24-hour accountability listed there. And then if I step into the right side, which is my professional life, there's a fair amount of overlap. Becoming a nurse manager or a leader in healthcare, like in many organizations, businesses, sectors, it really becomes a lifestyle where, when you step off of the campus, your work does not end. And man, was that true for COVID. In my position as the nurse manager, I started here as a nursing student. Then when I graduated nursing school as a nurse resident, then a staff nurse, then I became one of our clinical coordinators / charge nurses. Then here I am today as the nurse manager. My department has about 90 employees. We take care of over 40,000 patients per year. And as Claire mentioned, as the only trauma center in Chester County, our trauma service has a hand in the care of about 1,500 trauma patients per year. So what are emergency departments all about? We know that the stigma is time. I'm going to go to the emergency department. I'm going to wait for forever. But there's some thought behind that. The emergency medicine or the practice of emergency medicine, we know that we know a fair amount about a lot of things, but we don't have complete depth in anything. The heart, for example, we defer to the excellence of a cardiologist. We know for about 80% of the patients that go to a hospital, we're the front door, that if you're familiar with Paoli's campus, we're kind of at the backside of the hospital. People turn to ERs when they need help and answers fast. And then the idea of an actual versus a perceived emergency. Actual emergencies, this must be done now. We're facing something that's time-based, probably some instability. We need to take action versus perceived emergencies. We can kind of predict what our day will look like. We can't script what the day will look like. But when people come to us experiencing in their mind what is an emergency, our goal is to make sure that the emergency is not one that will cause lasting harm to them. So, people are leaving work, asking for prayers on social media, running red lights to get here. But the thought is, with the perceived emergency, take a deep breath. Getting here 2 minutes faster often won't change the outcome. And we'll make sure that when you get here that you're safely cared for. Of course, no appointments are necessary. Many people would think that Friday nights are the busiest time in an emergency department. By and large, that's not true. Most emergency departments are busiest on Mondays. Our lowest volume days are on Saturdays. And our volume patient arrivals starts to increase about 10 o'clock in the morning with our peak volume. The most patients in our departments at once is about 2 p.m. to 6 p.m. and then we start to taper off. Thinking like a nurse, and this is how I'll kind of guide us through COVID, is we use something called the nursing process. This is how we approach patients, clinical situations. So assess, diagnose, plan, intervene, evaluate. The assessment piece, I'm looking at someone, they're short of breath. My diagnosis might be, they have impaired air exchange. My plan may be to teach them deep breathing, maybe apply some supplemental oxygen. The intervention's actually doing that. And the evaluation is, how's that patient doing after I did my, my interventions. So if we think about that and where things were with COVID-19, the coronavirus that we're all familiar with, this is what our team was thinking of at the end of 2019. It's not uncommon for us to get health alerts or advisories from the health department, kind of emerging illnesses or hot topics that we need to be aware of. At the end of 2019, as the year was heading out, we heard things in the news about a respiratory illness afar. But if you see what we were looking at from a health department perspective or at the hospitals, the guidance of the health department at the hospital level, you'll see about 9 different topics. We have advanced knowledge on all of these topics. The only thing that we weren't too familiar with was vaping. We didn't know why there was this attraction to vaping. We were hearing things about popcorn lung. Certainly, we wanted to gather more information when patients arrived as to whether or not they were vaping. But none of the coronavirus or COVID-19 was on our radar. As a matter of fact, for my team, this is what we were thinking about. So this is a picture of medical staff, nursing staff, some of our health information, patient access peers, and our environmental staff. These are the people that support the emergency department, or a sample of those that support the emergency department here at Paoli Hospital. And this was our winter holiday party as a group at the end of 2019. And I think many of us, if we look at a picture like this, we can't wait to the day we can get back there. So then the first indication that we were probably going to be impacted by this was January 9th. Dr. Levine put a message out about this outbreak of pneumonia of unknown etiology. We don't know the cause, and it's from Wuhan, China, or in Wuhan, China. So using that nursing process, this is what we were thinking. Hey, there's a respiratory illness in China. We don't know a lot about it, but this feels a lot like SARS. It feels like MERS. Many of us may remember the media storm following the swine flu or H1N1, and certainly Ebola in 2014. When we were applying rules here, SARS spread worldwide in a few months. It spreads by droplet transmission, coughing, sneezing, talking in close proximity. So wow, does that sound a lot like this new pneumonia that we're hearing is in Wuhan, China? And guess what? SARS and MERS are both coronaviruses. So at the time in the ER, we like to play things pretty cool. We're thinking, we'll wait to see what happens when the time comes. I'll say that Ebola was the one that kind of shook us a little bit preparing for that. Nobody wants to experience a hemorrhagic fever. And if we paint a clinical picture, body fluids, whatever cavity they come from, that's blood tinged, certainly sounds a little bit scarier than a cough, and that's our way of thinking. February, much of the same. There's a respiratory illness in China, but hey, we also know that there's cases in Japan, Hong Kong, Korea, Iran, Italy. We still don't know a ton. We're going to wait and see. But one thing we know with a respiratory illness is we need to use great respiratory etiquette. Respiratory etiquette is not something new to healthcare. If someone presents to the hospital with cold symptoms or flu symptoms, they should be wearing a mask. We should be wearing a mask when we care for them. So the idea of this universal masking wasn't new to us, especially with the respiratory type patient. But again, our interventions, nothing currently needed, and we'll evaluate our actions when we need to, when the time comes. And then the floodgates opened. So whereas the prior slide, we had 9 different topics, over about 3 months, here's a 2-month time period where we're having a bunch of updates on one topic. We're hearing that there's a cluster maybe in Seattle on a cruise ship. We're starting to hear about maybe a meeting in Boston where people are traveling. The initial guidance was, hey, we should look at the Hubei province in China and who traveled from there. But now this suddenly gets a little more real. And then on March 11th, and we may remember back to this is when the World Health Organization declared this as a pandemic illness. 118 countries, over 125,000 cases. I think if you talk to anyone in healthcare, will say that number was probably much larger because as this evolved, we would get better at testing. We knew that there was a 13-fold increase in China. If I followed some of the guidance from some of my friends in a financial sector, they would say when business comes from afar that makes other countries look great, multiply it or divide it by 10. If it makes them look bad, multiply it by 10. But I think we were probably seeing a much bigger illness than we were ready to fight with. But the World Health Organization, what did they say? Prepare, be ready, detect, prevent, treat, reduce and suppress, innovate and improve. And I think if they could look back and say it again, they would say overcome. What did this look like for us here at the local level? I have 2 little boys. They went to school that day, but then school was going to be out for now. We didn't know how long. Arriving travel from some countries was put into effect. The thing that I laugh about with some of my neighbors is they say schools were closed on March 13th, and then 4 days later, the liquor stores were closed. How will I ever deal with not being able to travel and being at home with my kids? So if they had their coping mechanisms lined up, not always healthy, but this was one of the ones where they said, well, how about the liquor store? What did we worry about at the healthcare level? What if we had people in our community with chemical dependency and now they were missing that lifeline to something that is an unhealthy habit or an addiction, but maybe the withdrawal that could kill them? Alcohol withdrawal is one that scares us. And then finally, March 25th, we're hearing that there's this idea of flattening the curve and how it's working in China. And then even more updates on coronavirus coming our way. So mid-March, we knew that we kind of had to put a plan into action. This is spreading rapidly. We will be impacted. We need to do as much as we can, as fast as we can. And at the bottom there's a phrase that many different industries have used. I think my education colleagues use it most often, and that's that we're flying the plane before it's built. that we have to get this plane off the ground. And the challenge is when you're flying a plane before it's built and you're by yourself, that's okay. But suddenly we're flying a plane with a team. This is the team that we're leaning on us for the right answers when we may not have them. We have to put a plan in place to make sure that they were safe, to make sure that we could meet the challenge that we didn't know a whole bunch about. And then recognizing at the same time, if all of these people were concerned, all of these people were scared too. So for me, this is my family. I'll say it's my wife's side of the family, 5 kids, a bunch of grandkids. But in this picture, there's one healthcare worker, and that's me. But also in this picture, there's someone that doesn't have a spleen. You need a spleen to fight infection. There's someone that has battled a brain injury. There was someone, and you could probably guess who, would go on to become pregnant and then have a child. And then we don't know about children being able to transmit this illness. So if everyone in this picture had someone like this, part of our team, they were thinking of who's probably going to get this first. It's probably Bill or someone like Bill. So that's where I'll go into, what did we learn as we went through some of the coronavirus COVID-19 response. This picture here, I'll just tell you that this is our primary trauma room used at Paoli Hospital. What I tell high school classes when they come through, this is the room where we have probably saved the most lives. This is also the room where we have probably lost the most lives in the hospital. Kind of a sacred space. So our cautionary tales. First thing I'll say, know your team, know the people that are working alongside of you. And it might sound like an easier concept, but when you're going to have to come closer together as a team, it's going to help to know a little bit more about your team. Some organizations, they would require some of their employees to, on the back of their name badge, which we don't have here, write 3 things about you. What do you want the people that work alongside of you? What do you want them to know about you that may not be related to your occupation? So, those things for me could be, my wife is a teacher. I have 2 boys, and we like to be physically active, be it golf, pickleball. It's a fun little activity, but something to create conversation, to know the person next to you. But more importantly, when you're faced with a challenge of coming up with a plan, and when you're rolling out an idea, know who your innovators are. Know who's going to quickly adopt the thoughts that you have. Know who the early adopters are that will follow that early lead, the early majority that will follow with you, but also know those that may not come as fast. For us with coronavirus and what we were doing here, we never tested patients in their cars. We never approached patients in their cars. So I had to know on this team who I could turn to say, hey, we have this process. It's kind of undefined. I don't have all the answers, but I'm going to trust your expertise. And I knew who the innovators and early adopters were. The other thing with coronavirus testing, and this goes back to the World Health Organization of, detect. For us here, we had to go through this person under investigation process, and our early testing was through the health department. We know in Chester County that the testing was initially started for our region, really in the Exton, Euclid area. But, we also had patients that were coming from other counties, and we would have to call the health department to get a person under investigation, a PUI number, so that they could start contact tracing. But what did that look like when we started to see more patients than we had call takers? So we needed someone to come up with a process and to see how that would work. Certainly, we changed our nursing assignments, and we needed people that I could lean on to say, this is the right thing or the wrong thing, or those, not only do they know you, but you know them, and they can share their knowledge with you. Something that we went through here, we had a staff outbreak. And it wasn't with staff to staff transmission, but as we had an increase in community spread, we start to get concerned when your 90-member health team has 5 people that are positive. And are we spreading this here at work to one another? Or is this something that we're just coming to work with? And in that moment, our team, we tested 122 people in 40 hours that touched down in our department. And these are staff members. I couldn't do that by myself, but it was really beneficial to turn to those that were maybe looking for a moment to step up, potentially that leader without a title, who was willing to kind of carry this torch to the next shift. And then most certainly with our teams, and this is really important, we all pull a wagon when we come to work. And we usually say, check that at the doorway, come to work, leave what you can where you can, because when we're here, we're focusing on our patients first. But we knew that what if the employee had a family reduction in force, so their loved one wasn't working? What if their child had hybrid learning or complete remote learning? What about their family's fear of them bringing COVID home? So we had to know the team will work through some real things there. And one of the things that I'll highlight is, we're able to say to everyone, this is our employee assistance program. They may not be the be all end all, but they will help you get the resources or set you in the right direction. This picture here is just a picture of our outdoor tent where we were facilitating some of our outdoor testing. The next thing, trust your team. And I'll say that this picture somewhat illustrates that. I don't think maybe one person may have a drink in their hand, but who would you throw axes with that you work with? So make sure that when you're with the people that you're throwing axes with, that you know them and trust them. But with trusting your team, know that they're talented. The work that we're doing is not new to us. It's just feeling different. Know who we can turn to take the intelligent risk. Who in triage, where we assign acuity, who can I turn to say, this patient isn't coughing, but I'm worried that they have a fever. Who's the next person to go into a room? But the biggest thing, and I'll say this relates to the picture on the screen there, is the shared decision-making model. We didn't have all the answers, but who could I turn to tell me, hey, you're about to do something really silly, or I don't feel great about this. So certainly if you're going to repair a snowblower, do not dive in head first until another person makes sure that you're going to be safe. And the same could be true with any big challenge with your team. Before you dive into that challenge, make sure you have a great team with you that can help you make quick decisions, but also hold you accountable. This picture here, and this is the next kind of introduction to the idea of resiliency. Many of my staff, when we came to work in early March, a small tear in the eye when you see there's nothing more powerful than when you prove to yourself just how strong you are. And we didn't see a lot of coronavirus patients in the beginning, but the ones that we saw, they were scary, and we weren't the best at treating it because we didn't have all the evidence yet. So resiliency and all the things that play into building a resilient workforce really mattered. Community support, we didn't ask for that, but we were very fortunate to have that. We had many of the area police departments and detectives did a very long parade through our parking lot with their sirens and lights on. Community outreach for meal delivery was phenomenal. One of the things that we would then later go to discover is when a pizza is delivered and you're worried about staff transmission, you probably can't have 10 staff members unmasked in the same room, all touching the piece of pizza that they're tearing off to feed themselves with the piece that they're handing to their peer. So I think you'll see in many organizations that there's been a move towards individual meals. Lots of cards. Certainly we had the first responder clap off. And then we looked at other things across our organization. We knew that if we could connect patients with their families, that helped us as kind of the temporary patient's family member to connect them with their family. We also in our organization had the end-of-life support team. What do we do for our peers on the COVID unit that were facing death at a much higher number than they have before? And what we did across the organization is we looked to ensure that not one nurse was showing up every shift and having to be with every one of their patients at every time that they were passing. And we had volunteers in different level of cares across the organization that went there to be with those patients, to connect them on FaceTime with their families, with the idea that no patient should die alone. But on the other side, no staff members should have to carry that weight by themselves. And something that we do prior to COVID, but continues now, is a moment of silence and a pause. And the words are on the screen there, that we would say after someone passes, where we recognize the patient, we say their name, we know that they were loved and they had the ability to love someone. We know that they're a family member and friend. And we also want to recognize those that care for that person. We follow that with a moment of silence. Another thing, resiliency, here's just a picture of our team with the first responders. Another thing that we're fortunate in this organization, and this is not something that's distant to many organizations, is how are we dealing further with resiliency? We know that there is a level of compassion fatigue when caring for others, but we also know that there's the idea of psychological first aid, and we need to care for ourselves. So our organization, we are very fortunate to have a clinical pastoral education fellowship program. And this is one of the initiatives that they're doing. And it really helps to have a non-clinician whose focus is the emotional and mental toll for those that are carrying a pretty heavy weight. And then more pictures here. Next idea is the idea of networking. This is kind of, and I think Mike may have mentioned the idea of networking in his introduction. This is what we first were looking at in the beginning of March, as to what does this look like when we're taking care of these patients that we haven't seen yet. You'll see some things on here that then were proven to be inaccurate, like the chloroquine type medications. Tamiflu was on there. We know that that doesn't work. But remdesivir is on here. Corticosteroids are on here, and we knew that they would become some of the kind of standards for treatment. Fluid sparing resuscitation. We're not going to give a lot of IV fluids to someone with this pneumonia that would impact their lungs. But the idea of networking at the local level, at our hospital, we're fortunate that we had a leadership, and we do this every day. This wasn't something new to us, though it took on a new purpose. 9:30 every morning, we have a daily phone call with the leaders of all of the departments in our hospital. In the emergency department, at 11 o'clock in the morning and 7 o'clock at night, when we experience our greatest change in staffing, we have a team huddle. Usually our huddles consisted of a lot more of what equipment is changing, where are our risks on the unit, are there any new processes? We tailored these to meet COVID to say pretty much what are the biggest things that we need to know today, right now, knowing that, yesterday may have seemed like weeks ago, and time changed quickly with COVID, and boy, did it move fast. External networking, regardless of the industry that you're in and who your competitors may be, it's always important to know what they're doing. And I would say, as a healthcare community, one of the cool things is that we weren't just mainline health dealing with this. I wasn't just a leader in Paoli Hospital's emergency department. We were able to lean on our peers, our colleagues, those in that next agency that's working alongside of us, to see what evidence do they have, and how could we be better. So one thing that was initiated somewhat quickly in our county, all of the emergency department managers and directors, so my position in the equivalent at Jennersville, Brandywine, Chester County, Phoenixville, and then our EMS, so our ambulance-based colleagues, we would have phone calls just to see where we stand. What are the changes with the volume that you're seeing? What's your visitor policy? What has changed today? What has changed since last week? And that helped us kind of hold ourselves, to a standard, but also understand the standards of others. It also helped beyond, so regional, emergency nursing and healthcare, though it's a large industry, it's a relatively small community. So when we hear that, at Einstein Hospital, they're reusing their gowns, but they're spraying them with a chemical between reuse. It really helped because, we didn't have a chemical here at Paoli that we could spray our gowns with. and we couldn't hold it to be true that we were working with the same sets of tools. And all that took that morning was an email to my colleague at Einstein to say, hey, what are you doing? And then we found that they were using a different gown and that their PPE supply was a little bit different than ours. So they're approaching it differently, but it helped with that network to keep us accurate or honest, I would say. And then the social network for us. We were leaving our houses where people were concerned about us. One thing that we were fortunate about is we had our best friends at work. We had those that were at work doing the exact same things that we were doing. And it almost felt like we had a sense of normalcy. So though coronavirus or COVID-19 changed the way we were doing things, it was great to have the people next to us doing the same things. Where we could talk about, when I go home, or the leadership of my child's school, or my neighbors are part of my small circle, they're part of my bubble, but they don't want their kids to play with my kids because I work in an emergency department. So it was great to have those people that we could lean on and talk about the same things. For me, I mentioned already, my wife is a teacher. So being able to talk to her about the challenges that she was facing, and some of these challenges are not too distant from any other industry. Think about the essential employees, our grocery store workers. Who could they turn to have that real conversation? Probably the people that work with them. For us in the ER, who did we see most often? Our police, EMS colleagues, as well as our coworkers. And then my last topic I'll say is communication. You see me in the picture here next to me. That's Dr. Stuart Brilliant. He's our chief of emergency medicine. And one of the things that we recognized was that we needed to work in concert and share the same types of messages. So in this picture here, if we're going to tell our team that we think vaccination is important, then the two of us better lead the example. So this is at 5:45 in the morning when on our first day of vaccinations opened up to the front door of our hospital first, the emergency teams. And Dr. Brilliant and I made sure that our appointments were there at the same time together, so that we could take a picture and show our teams that if there was concern about a vaccine, that we were going to dive headfirst into the snowblower because we had faith, and that we were going to hold each other accountable. Communication for us, walking the walk, like I said, with the COVID vaccine, that's a big one. If we had changes in PPE, for example, the N95 mask, we know that the burn rate, how fast you're going through N95, we had to slow down. We had to reprocess those using an emergency approved cleaning mechanism or sterilization mechanism. If we're going to tell our team that we're going to do that, well, then they better see me with my name on the front of my N95 and the tally mark of how many times it's been through the sterilization process. COVID was not a time for do as I say, but not as I do. So a big part of the communication was really walking the walk. Self-care, this is, me, the biggest cautionary tale. We probably could have been better as leaders looking back at showing our teams that we're going to take a day off. I want you to disconnect from work when you go home as much as you can. We probably could have walked that walk a little bit better. And the last thing with communication is transparency. Organization here, we have weekly town halls. We've continued those to this day. They're with our chief nurse and our CEO or our president of the organization. That's every Wednesday at noon, where anyone has the opportunity to ask a question, and hot topics are really discussed quite bluntly, and there's no smoothing the edges. So the transparency is key there. We have a COVID-19 landing page where we'll direct our team members to. This is the up-to-date source of truth. Go there for information. How you communicate change is important. And the last thing that I will say, and I'll close with this, when experiencing change, the biggest challenge for teams, knowing that they're getting information from every direction, is how upsetting it could be for the message, didn't you read your email? Because when things are changing so fast, The change that they're asking you about could have been 10 emails ago, and the email that you just sent could change in the next 2 hours. So with that, I'll close. I'll turn it back over, and I really thank you for allowing me the opportunity to meet and discuss our experience here today.
Thank you, Bill. That was great. And so we'll be taking questions at the end for Bill. Next, I'd like to introduce Karen Flaherty Oxler. She is the Executive Director and the Medical Center Director for the Corporal Michael J. Crescenza VA Medical Center. Karen spent more than 2 years as the Deputy Surgeon General and the Deputy Chief for the Bureau of Medicine and Surgery for the United States Navy. She has served as the 22nd Director of the Navy Nurse Corps and proudly calls herself a Navy nurse. I am so humbled to introduce my mentor and my friend, Karen Oxler.
Oh, thank you so much, Claire. Let me make sure I can try to share my screen. Let's go. All right. Do you see the slides, Claire? Let's see.
No, not yet.
All right.
Oh, yes,
well,
yes.
Now, okay, very good. So thanks, everybody, and really good morning. Bill, that was just wonderful. You gave us an opportunity to talk a little bit about what was going on, to listen to you, to understand all the pieces that were important and essential as we looked at this different time this last year. I am the Chief Executive Officer, Executive Director of the Corporal Michael J. Crescenza VA Medical Center here in Philadelphia. And I am the first woman, the first nurse, the first clinician to be the director, and I will have been here 2 years in June. We are a medical center and 5 community-based outpatient clinics. And Claire, let me just double check.
I don't see them now. I don't see them now. I'm sorry.
Oh boy. What about now?
No.
Okay. Screen one. All right, let me just make sure, got everything going here. All right, share screen. We practiced this earlier, so this is the first thing that you do. Let me just, this could be screen one. All right, well, you know what, I'm gonna keep talking. I'm gonna get my colleague outside my office door to come in here and make sure we're doing the right thing, okay? Stand by, thank you. Claire, fill in for a moment, will you?
Absolutely. So in addition to Karen's career as a Navy nurse, she received her master's degree in nursing administration and a certificate in administration from the University of Pennsylvania. I now see Karen's slides. I now see them.
So you do, Claire, you do see them
I
now?
see them now. Does everyone else see them?
Yeah, I did.
Okay.
There you go.
All right. All right,
Thank
thank you. Thanks very much.
Get rid of that. Oh,
Okay, all right, thank you. So this is what we look like normally with the masks on. Thanks, Matt. So as I was just saying, we are a medical center here in Philadelphia, and we are located at 3900 Woodland Avenue, so right across from the University of Pennsylvania. We have 5 community-based outpatient clinics that are part of our portfolio of care for our veterans that are 66,000 veterans. So our community-based outpatient clinics are in Pennsylvania, and they're in New Jersey. And we also have a continuing community living center, which is just across the street. So that is where approximately 80 of our veterans reside as their home. So that is their residence and that is their home. So Bill did a fabulous job of really talking about how things changed pretty dramatically a little bit over a year ago. We are our academic partners, the University of Pennsylvania. So I say that to kind of tee up where we are and who we are. Corporal Michael J. Crescenza, the VA, is named after this young Philadelphian who at 19 years old was in Vietnam and 3 separate times went back to save his team. He was awarded the Medal of Honor for his heroism. He passed the third attempt to attack a bunker and save his colleagues, resulted in his losing his life, but he saved all of his colleagues. He is the only Philadelphian to receive the Medal of Honor, which surprised me when I first learned that. But certainly when we think about this organization, we think about coming through these doors, it matters significantly. We care for 66,000 veterans. So when I say care for, it means that their primary care needs, their psychological health needs, all of their critical care needs, all of their other needs, whether some be in the community or some be here, we are responsible for that. So let me just make sure I can advance the slides. Just let me know, Claire, if the slide goes forward. All right, let's see. Here we go.
Mhm.
So what changed? About a year ago, a little bit over a year ago, maybe 56 weeks or so ago, we started seeing evidence. We saw our first case of COVID-19 in early March. And I think it was really important that we looked at how do we provide care? I talked about the 66,000 veterans that we care for, and they were dispersed and throughout. Yet many would come here. We would have between 2,000 and 3,000 people in our hospital here proper each and every day. The halls were full. We were busy. Many had psychological health challenges. They saw behavioral health. We have 4,000 seriously mentally ill veterans in that cohort of 66,000. But we have 5 different generations of veterans. So we have veterans that were World War II veterans. So think about the geriatric care needs. We had Korean War veterans. We had Vietnam era veterans, and that was primarily the largest group. And then we had post 9/11 Desert Storm veterans, post 9/11 veterans, and OIF, OEF veterans. So we had veterans that were from 30 to 90, 100 years old. So 70-year lifespan of care for these veterans. So I knew that the care needs that they had would continue. And once we determined that something was different than just, we're seeing a few more cases coming through the ED, or primary care is hearing a little bit more about some respiratory issues that some of these veterans were having, we then determined that something was different. The really good news is Penn is across the street. And the really good news is most of our providers are on faculty at Penn. So we had great collaboration, great conversations. Yet we knew we needed to care for our veterans and really looking at the resources that we had. But to do that, what were my priorities as the leader of this organization? I had to make sure the teams were well. I had to make sure I paid attention to the frontline team. And that frontline team really was about making sure that people came to work. But thinking about this, Bill talked a little bit about this. My frontline team members, age demographics there as well. So I had team members that had children that were out of school now. I had team members whose family members were ill. I had team members whose team members were ill. I also knew that they needed to be here, be present, be here safely. So healthy, vibrant teams and partnerships were really, really critical. The frontline team is listed here first because I do believe that that is the most important piece. You take good care of your team, your frontline team members, they will take very good care of the people that they service and they care for, and that would be our veterans and each other. The management team, I knew that they needed to be supported to be here as well. I knew that they needed to support the frontline team. What we've learned over time is that people make decisions about joining or leaving organizations based on the leadership, the leader that they work for or supervises them. So that's the management team. The management team is there in the middle. They're answering questions. They're often the first ones that the team member will ask something about, ask for clarification, ask for insights. And it really was important that they had front and center, they had the information that they needed to be able to offer to this team of 2,800 team members, clear information. And then the executive team, we immediately went to stood up incident command to run the day-to-day operations during this pandemic. And then the rest of the management continued to continue as well. So what we found that really were that communication. And Bill talked a little bit about this, but that was a priority every single moment, every single day. You couldn't do it enough. we had the tools, we had the supplies, we had the support to be successful. We're part of a network, we're part of 9 hospital system that is in Pennsylvania, covering the western and eastern part of the state, in Delaware and New Jersey. So I had sufficient inventory. I had, the proper PPE to keep our team members safe. And we'll talk a little bit about this in a moment, but those were critical pieces. When you have a pandemic that hits such as this, and you don't really know what it is, you can't label it, you can't really describe it, you can't really understand all the pieces, you need to control what you can control. And we were able to provide information. We were able to provide clarity around the priorities. We were able to institute and relaunch safety huddles in a different way to focus on care. The picture you see here are some of our young researchers who were at Penn, but were part of a detail here working with us. And they are looking at how they would create, using a 3D printer, some masks. So these are N95s. Now, we didn't need to use them, but that was an important role that they were playing to be able to say, could we become even more self-sufficient? So number one, they're highly engaged, highly energized. They were innovating. They were looking at ways to provide support to the frontline team members. And so this was really, really important because it allowed us to, I would say, elevate and creates a bit of normalcy around the abnormal times. There were so many common threads between the care of all of these teams. Communication was important, making sure they had active listening sessions for their teams, each other, as well as making sure that they would raise their hands, ask the questions, nothing was off limits, everything we needed to hear. So from a leader perspective, you only get that if you're visible. You got to walk around. You don't spend time in your office. You don't stay behind a door. You have to be visible and have to be out front. We were moving fast. Things were changing pretty quickly. And it was important that the trust, the transparency, and the nimbleness continued throughout this period of time. All right, so we were all faced with fear. Streets were closed, city blocks were closed. We had a stay-at-home order, except if you happen to work in healthcare and you needed to be in to care for people. We needed to make sense out of what was happening. So a couple things here I want you to think about. How do you reduce fear? The team that you see here is my 5Es team. The 5Es team was the clinical nursing team who, prior to the pandemic, took care of general surgery patients. We converted that unit to a COVID positive unit, and this was the team that stood up that unit that then created a caring environment for COVID positive general patients. Our MICU was the designated COVID positive ICU, and both of these teams pivoted pretty quickly to do what we needed to do. You reduce fear by being present, by being willing to listen, be willing to answer questions, be willing to say, you don't know. You reduce fear when you're side by side. You reduce fear when you make rounds 6 days a week and you come in and out of the organization and you do things quite successfully in regards to listening. And often it was that people just needed to see somebody, talk to somebody, see someone from the leadership perspective, and also be able to just have you listen to what was happening, what was going on. What did that take from the leadership perspective? It took your time, it took your attention, it took your dedication, it took your willingness to say, I don't know. It took the willingness, though, to say, I don't know, but we'll figure it out together, because then you start solutioning and you start creating a little bit more normalcy around what is happening, if that could even be possible. I mean, we knew that team members were coming to work when their family was ill. We knew team members were coming to work when they were worried about what was happening around them. They needed to not worry about when they were here at work, that they didn't have the PPE they needed. They needed to not worry about craziness about scheduling. They didn't need to worry about craziness about, if I'm out, can I come back? We had a very robust occupational health team who took good care of everybody. We had our own lab in-house that could do rapid testing. So if a patient came in through the ED and they were going up to this 5 East team that is right here, we could have tests resulted. So we would know whether the veteran was positive, a PUI positive or negative. And that really was a game changer. Our team here was really, really critical. They've done over 500,000 tests for this organization as well as our network. So that was very much allowed us to help create a little bit of control. We did, when we looked at this, I also needed to, from a leader perspective, try to understand who I needed in the building. And we had sufficient technology. We had done some telework before. I talked a little bit about the primary care needs of our veterans previously. And remember that those care needs continued during this period of time. So maybe the 2,000 to 3,000 that were in here on any given day were no longer in here, but they still needed care. So we had the ability to do telework. We had the ability to do telehealth visits. We had the ability to do video connection visits with our veterans. We had the ability to make phone calls. We also had the ability to move some of our team to telework. So you think about some of the functions in the organization, and some of those were clinical functions as well out of primary care. We were able to move and pivot pretty quickly to that. And so that was really important as we started to look at keeping the organization safe. If I had less people in the building, that meant that I had less team members I needed to screen each and every day. That meant that I had less team members that may need to have an occupational health visit. And that meant that I didn't have team members that might be exposed going home. So all those things, I mean, we didn't have months to study this. This was all about relying on your team members, relying on the insights, making the best decisions that you could at that point in time, and being willing to say, you know what, we're going to change this right now, but not change things 25 times a day. Try to have a pacing that made sense. The watershed moment for this organization to reduce fear happened about 3 weeks prior to, 2.5 to 3 weeks prior to when the CDC mandated masking in all facilities. I mandated and we distributed N95 masks to all the team members on I'll never forget, on a Friday out of the boardroom that's down from my office here. We had all the service chiefs. So those are your senior leaders, most of them clinical service chiefs, as well as administrative service chiefs, come down with a count of the team members that they had, and we distributed N95 masks. The fear in the organization went from here to here. Now, I didn't know if that was the right thing to do. I thought it was because my chief of staff, my chief medical officer happens to be an ID doc and happens to understand, and we had thoughtfully talked about this, but you got to make a decision. I didn't seek permission from my network. Either I was going to get in trouble or it was going to be the right decision. For this organization, it was the right decision. And the right decision was to reduce fear, and then people wore their masks. And then we were in masks earlier than the rest of, I would say, some healthcare in the city here for all the right reasons. Team members came to work, they kept coming to work. We didn't have absenteeism problems. So that was really a watershed moment. And it was something that the team was really proud about. It was intentional that the service chiefs get distribute the masks themselves, because that then was that important point and that important visible moment where I have a senior team member worried about their team. We're distributing masks. We think it's the right thing to do, but we'll course correct. Now, then we added goggles, and we went into goggles for mandatory use of goggles or face shields prior to any place else. But again, that's what this team needed. And, we're really glad that that happened. And without a beat, we went on. All right, resilience. So you get rid, you eliminate as much fear as you can. You don't ever get rid of it, but you eliminate the fear because you communicate, you're present, you're visible, you're answering questions, whatever you need. And then you try to say, okay, we thought this might be, maybe this would happen for a few weeks. This might go on. We're a year out. It's continuing. We still see evidence. Our numbers yesterday were the highest number of inpatients we've had since about, I'd say 48 weeks ago. So the numbers are still here and the variants are still here. So what did we need? We needed a team to be resilient, and that's the entire team, the 2,800 team members, those at home teleworking, those at home, because the worries were still there at home, those here in person, and then being resilient and with great fortitude, being able to care for our veterans. We needed to understand what was happening today. We tried to look at what was happening tomorrow, and we'd look about a week out. We didn't look a month out. We didn't look 5 months out. I mean, I was looking that far out to try to make sure we had everything paced and prepared. But it was really more about creating a battle rhythm, that people had all the training that they needed. They had the teaching moments were created, that they had the support that they needed, whether it be equipment, whether it be technology, whether it be a listening ear, whether it be just, this was a moment of celebration. We welcomed our team in unexpectedly one really cold morning. I think it was April, early May, but it's a cold morning. You see people in warm coats there. Unexpected. People were, the team was overwhelmed by it. We had tears, and this is the executive team and the service chiefs who distributed those masks, remember, about a month ago, 2 months ago, perhaps, out there welcoming the team into work each shift. Tears in the eyes of these team members. You know, some of these are some tough team members that have been here a long period of time. This is a gritty place. This is a place that has pointed elbows. This is a place that we don't have any challenges, any worry about challenging each other in a kind and respectful way. But we started talking more about how are we resilient as a team? How can we support each other differently? How can we be kinder? How can we be a little bit gentler in our communication, et cetera? So this was really about today, tomorrow, next week, and pacing. Didn't know how long this would last, and we now know it's, you know, certainly lasted quite a bit of time. This is about checking in communication, because I can check in with you yesterday, but if I don't check in with you today, stuff may have happened between yesterday and today. So what happened in that last 24? What I learned in my time in the military, and I spent 38 years in the Navy and did some work for the Navy and the Marine Corps about psychological health and post-traumatic stress, traumatic brain injury. If you talk to people about sleep, they'll talk to you about sleep. They may not talk to you about how they feel, but if you ask somebody, how'd you sleep last night? And they may say, you know, I didn't sleep too well because I was worried about X. There's your foray. There's your conversation starting point, where you can go in and say, well, tell me a little bit more about that. How'd that make you feel? You know, you think about the 66,000 veterans that we serve and we care for here. We worry about suicide. We worry about self-harm. We worry about all those things. And then layer a pandemic, layer isolation, layer depression in with all of this. And you may have a disaster waiting to happen. So I wanted to make sure the team was resilient. I wanted to make sure that they were connected. I wanted to make sure that we were checking in with them, the communication was there, and we could control what we could control. What's that? We can control how we show up. We can control the learning that we anticipate we will be part of every day. We can control the listening, how well we listen. We can control how we communicate. And we can certainly control how we could create a predictability about what was next in an unpredictable time. So really it was about supporting each other formally and informally. We started Camp Resilience, which is, you know, kind of just a check-in. So at 12 o'clock, some of our psychologists, and we have over 140 social workers that are part of this team. We have about 100 psychologists that are part of this team based on the demographics of the veterans that I described previously. But you know full well that you care for each other as well. So if my chief of behavioral health, who's a psychiatrist who got the national award for research this year, he would talk about tea time, and he'd check in with me. He goes, "Is it time for tea?" And I go, "You know, it might be time for tea." So he's checking in on me, I'm checking in on him, and we're just making sure we checked in on each other. So serving our veterans, they needed to make sense as well. These veterans have all either been part of they've been part of a military system, they've been part of healthcare in the military, they've been part of veteran care. Some have deployed, some have been at war, some have served, you know, in country here, some have not been overseas, but they still needed care. And we have 66,000 enrolled veterans. You'll see in a moment that we have 46,000 vulnerable veterans that need a little bit more of our care, that received health care with us. They needed to make sense out of today. So there was confusion. We had, as I mentioned, a large component of our veterans receive behavioral health. So we're part of a model that they help manage their life, manage their care, manage their success through support from others. A lot of that is face-to-face. A lot of that changed. So they needed to move to some video connections. Some didn't have the capacity based on the economics, based on the social situation to be able to do that. So we relied on community partners. They reached out quickly. Donation of some smartphones, donation of some iPads, et cetera, to be able to do that video connection. We have a growing, and the largest growing demographic of veterans here at Christians is women veterans. And so we have about 11% of our veterans, and fastest growing is women veterans. So we needed to make sure those care needs were continued, and that we could do that in a remote way. What are some of the veterans saying about this? They liked the idea of they missed the face-to-face, because often there was a social connection of seeing their colleagues and their contemporaries. They missed the face-to-face. But what they did say is that the iPad connection, so the video connections, the telephone or the telehealth connection, created a level of intimacy that perhaps they had not experienced previously, because there wasn't the distraction of trying to get downtown here to the city to find parking in a crazy parking lot that is always full. There wasn't the stress of driving. There wasn't all that stress. They could focus on their provider, who was face-to-face with them and a very short distance away, like we are today. So that mattered. So we had to really change that, blended care model. Good news, we had the talent, we had the technology, we had resources to be able to do this. We have appropriations. The VA is funded through appropriations from Congress. It's 2-year funding. So I wasn't worried about budgetary impact at that point in time. We could buy the laptops, we could get the laptops, imaged, we could get them out to the team quickly and safely, and we could continue care without interruption. It took a lot of, fast-footed speed, I would say, and the team members had to be pretty nimble and pretty flexible. But the good news is we were determined that the care would continue. Our veterans are vulnerable. There's money insecurity, there's food insecurity, there's concerns about housing. So again, we have a homeless team that is out in the community that looks for veterans, looks for people that may be at risk. The pandemic did create risk. We have 1,200 veterans that are housed in temporary housing who had been homeless without this housing. So they're housed in, I would say, group homes or group settings. Think about a group setting where there might be 4 in a room in a pandemic with a virus that spreads. So that team had to really pivot quickly to think about how they would provide care differently. Because for the veterans, tough group of men and women, and really tough. But who's tough in a pandemic when you don't know what's going on and you're trying to figure out what is normal for you isn't normal any longer. We have a high, now it's about 400 veterans that are still part of methadone maintenance program that is on station here, that we have had in place for 20 plus years. But again, think about this, people weren't coming in on a daily basis. People weren't coming in a couple times a day. That team needed to pivot pretty quickly. So I am so proud of the team to be able to do this, because without a beat being missed, the veterans were cared for, and they continue to, I would say, be successful during this period of time, and some actually really thrive during this period of time. Food insecurity was significant. Before, veterans would come in here, they may have, based on the economics, they may have food here in our canteen services, our cafeteria. That was not available because they weren't in the building. So we needed to make sure that food was distributed to them. So once our patient advocate team made calls, and they reached out to all of our veterans that they were worried about, our social work was worried about. They asked in a very kind and gentle way about food insecurity. People were not afraid to speak up. We were able to, first off, we had a drive-by where food was picked up. Then that wasn't going to work as successfully, because we're talking 400, different veterans needing food or food support to their family. we then delivered the food. And so the team got in the vehicles that we had, safely went, transported that. And again, you know, you do what you need to create a new normal. The picture here is a couple of our EMS team members who kept clean our facility, our environment, so that we could not have to worry about infection control. We worried about it, but we didn't have to worry about cleanliness. And we augmented that team to be able to have people cleaning surfaces hourly as we were going through this period of time. All right, so let's turn to a little bit of hope. And this is a shot of a vaccine clinic that we did in Runnymede, New Jersey. And I was there again with the team on Saturday when we were doing our second round of second doses for some of our veterans that live in New Jersey. So when we think about vaccine, we have had Pfizer vaccine from the very beginning. We have ample supply. We continue to receive supply. The target for us was about 46, and the number keeps changing, 46 to 47,000 vulnerable veterans that described by our central office that should be vaccinated. And so then you start the journey of the conversation about, do you want vaccination? What would that look like? And also vaccinating our team members. So our strategy was that we have supply. We want you to get vaccinated. Again, veterans have been in the military, have received vaccinations throughout their career in the military, but that doesn't mean that this was going to be easy. This was still emergency use authorization, and this was still some skepticism that existed. When I look at our, well, let me talk about our team members first, and then I'll talk about the veterans. The team members, I have 2,800, depending on when you count what day it is, team members. And I have a force, 57% of my workforce is Black, Asian, Hispanic, 43% are white. So as you can see, we represent the community that we serve because the demographics of our veterans are quite similar. I know that the team needed to be, I knew that our likelihood of success was determined by our team being vaccinated, our team feeling safe, being willing to take the vaccine, even with EUA. There was no mandate through VA that this was required or necessary. It was strongly encouraged. I chatted a little bit earlier about Dr. Kelly. Dr. Kelly is an infectious disease specialist, and I'm pretty determined Irish lady. And so I knew that we could do this. I figured that, well, okay, let's figure this out. Let's go one-on-one. Okay, so the first vaccination we had, we converted our multi-purpose room to a vaccine clinic. We had everybody excited and energized. The hope in that room was palpable, the first vaccination of the first group of team members. So successful that amidst all of the challenges, amidst all of the conversations, the discussions, we've been very successful. 99.7% of this team at Crescent is vaccinated, and that first and second dose. So we are so excited by that because they then become community partners to talk to the veterans that they serve in the community, to talk to their, speak with their family members to encourage and reduce any vaccine hesitancy that might exist. So we continue, we did close to 400 vaccines yesterday. We will continue daily until our supply is exhausted, but we are starting to see really that there is a little bit more hesitancy. The J&J pause has impacted. I've got about 2,900 doses in inventory here for J&J. That's impacted a little bit of hesitancy, but again, we'll be fine. All right, so excited that we're still determined we will reach all the veterans. We are at 53% of our veterans are vaccinated today, as of today, and we look at that daily. We have a 9 o'clock safety huddle with our network, and we talk about vaccines. We talk about vaccine operations and all kinds of things every day. And that has continued since the pandemic started. So over a year, we've been having this daily phone call. What did we learn? So, and then I'll pause and get off the, then I'll just, well, I'm gonna go to the next slide because I want to finish my last note with this. Hope and vaccine. This is the COVID crusher team. This is the team that were the first team that did our screening. They were the team of nurses and other team members who were mobilized from current assignment to new assignment. And they rocked it. They crushed this. They were so fabulous about the work that they then started to do. It was intentional and important to me, and I put a personal stamp on this. I wanted team members welcoming team members each day during this pandemic. I didn't want rent an agent. I didn't want somebody that they didn't know. I wanted a team member. In the front here is the nurse manager for the specialty care areas. She led this team. I wanted team members welcoming team members in. So we learned that we're stronger together. We learned that we're strong, but we're stronger together. That you never can communicate enough. That we lift each other every day. A small smile. You can smile with your eyes, and we learned how to do that well. A small smile can make the day of somebody else. We know that hope continues. We know that 53% of our veterans are vaccinated now. Yet what about the other 47%? And so we know that this is a journey. We know that people can have a moment. I say, if you have a moment, go home, come on back, push the refresh button, come on back in the building and have a better moment the next day. And with that, I will pause and just say that this has been an extraordinary time to be in healthcare. I deployed a couple of places in the military, and it was responsible for a couple of significant disasters that had occurred. But I think this one in particular, in the private sector, in the nation, and having a national impact, we have learned a lot about each other. And I would say that as a nation, we're resilient. As a group of colleagues, we're better when we are good to each other. And like Bill talked about, we started a few things that we do on a daily basis. I send a message. I was sending a message every other day. Email message. I send a weekly message. It goes out every Friday. People look for it. I still get comments. We're 55 weeks into this or whatever. We have town halls every single Wednesday at noon, similar to what Bill talked about. We had 700 people on the call at one point in time. Now we average about 100, but we're talking more about variants and different things. But the entire leadership team is there, and we, kind of run it like a talk show. I read the questions. I'm the MC. I read the questions, and couple things happened there. The team at large saw the, I would say, the human aspect of their leadership team. They saw the authenticity of their leadership team. They saw that their team could be good with each other, kind to each other, laugh with each other. And it created, I would say, a bit of normalcy during a crazy, abnormal time. So I'll pause now. And again, I'm so thankful to have been part of this conversation. I learned so much from Bill. And I'm excited that we have team members in this organization that are excited and energized to be part of providing healthcare for the future. So thanks again, and thanks, Claire, for the invitation.
Thank you, Karen. So next up, we're going to talk about our Champion of Training and Action team. Just want to give a thank you out to Pam Dovish, Director and Support Executive for Revenue Cycle Back Office Support for Cerner. She is instrumental in the discussion with her team around our next guest. So one of the key directives from Governor Wolf this year was to establish Pennsylvania as a trauma-informed state to better respond to the needs of people who have had adverse childhood or serious traumatic experiences. So in December of 2019, Daniel Jorman, our next speaker, was named the first executive director for the Office of Advocacy and Reform for the Commonwealth of Pennsylvania. Welcome, Dan. We're excited to hear your presentation.
Thank you, Claire. Good morning, everybody. Give me just a moment to share my screen with all of you, and we'll get this set up and started. There we go. Good morning. As Claire said, my name is Dan Jorman. I am the Executive Director of the PA Office of Advocacy and Reform, which is within the Office of the Governor. As Claire said, I started in December of 2019. The governor had actually created the Office of Advocacy and Reform through executive order on July 31st of 2019. And certain incidences, in particular, the abuses at Glen Mills had been a big driver of the governor wanting to look at how we were caring for all vulnerable populations, and that's all vulnerable populations. So, you know, children, seniors, people with intellectual and physical disabilities, minority populations, people living below the poverty line. And I've joked with many people that my career has been so varied over the years, working with all those different populations, that my career only makes sense if eventually there's an Office of Advocacy and Reform for me to work for. Um, as fate would have it, and has already been covered by Bill and Karen, you know, I was in my office for 3 months before we were sent home, and struggling with this pandemic. I also, throughout my work, have blended my anti-poverty work in my career with public health, and ended up working very closely with the University of South Florida when I lived and worked in Tampa for about 4 years. And in Pennsylvania, I've served for about 6 years on the community advisory board for the Penn State Hershey College of Public Health. Excuse me. So epidemiologists have been some of my closest friends and colleagues for years, and so it's been a struggle, but I also think there's an opportunity to talk about vulnerable populations differently, because the pandemic has so clearly demonstrated where the flaws in our systems are. So with all the different things that we could have focused on when I came in December, we decided that becoming a trauma-informed state might be the most important thing for us to get underway. And the reason for that is that throughout my career working with these vulnerable populations, the one through line that I saw again and again with every one of those seemingly different populations, besides vulnerability, was trauma and chronic and toxic stress, scarcity. These things just kept showing up. And so working in anti-poverty work, I worked at 2 different federally qualified health centers in my career. I worked in intellectual disability services. And so the community ills and challenges that have been with us forever all have this through line of trauma that creates a feedback loop between that issue and trauma itself, where they just keep feeding into each other and making the situation worse. And so both in thinking about some of the key reasons our office was formed, you know, trying to change culture around how we approach vulnerable populations, trying to move from a punitive model or a model that asks people what's wrong with them, to move to a model that's about healing and that asks people what happened to them, so that we can help them process that and heal from it. Another way to look at that is a concept called a syndemic, where you have multiple health problems that are linked by some issue that connects them all. And so again, just a different way to think about that in terms of all of these different things that are challenges we have, some of which we know have gotten worse as a result of the pandemic. There's been a lot of concern about domestic violence and child abuse, you know, alcoholism and substance abuse, all of those different factors made worse by the additional stresses and traumas of this pandemic. Our approach was to form a think tank of trauma experts from all over the Commonwealth. I was originally hoping I could get 10 folks who would be willing to do this work for free as volunteers on a think tank. And when I put out the call, we had 68 applicants, and I'm not kidding, every single one of them could have served on a think tank. It was an amazing group of people. I ended up increasing the size of the group to 25 members, and we spent between March and June meeting, and thankfully, because I wanted geographic diversity, I wanted people from urban, suburban, and rural parts of the Commonwealth, it was always going to be a virtual meeting platform. So the pandemic did not slow us down. And we started by defining the terms that we would use together as a Commonwealth to make sure that we were all speaking the same language. I know organizations that, you know, they sent their staff to one training on trauma and said they're trauma informed, you know, and others who've taken these huge journeys of creative transformation around trauma informed and healing centered care, and all using this, all saying that they're trauma informed, even though they were doing very, very different things. And so we wanted a common language. We wanted to set mission, vision, and values for the effort to really make sure that we were a cohesive group moving forward. We didn't want to just write a plan that would gather dust. We wanted to be able to make sure we implemented it. We wanted to build a network to connect all the different community-based grassroots movements that had already been going on across the Commonwealth, in some cases for decades. So we didn't want to get in the way of anyone's work or try and co-opt anyone's work. We wanted to support it and connect it so that they were connected to other organizations, county-wide coalitions, initiatives, so they could learn from each other, so they could mentor new communities of practice, and really be a support in connecting the dots around what this could look like across the Commonwealth. We wanted to change things at the state level, affecting culture, policy, and practice. Super important that this gets embedded into the culture of the Commonwealth and isn't just something to check the box on. The same thing for organizations. This has to become a part of culture. We also wanted to talk about healing from the trauma of a major disaster like COVID-19. That wasn't on our radar when we first started the call for people at the end of January, but it certainly was by the time I was interviewing candidates in March. And then healing from the damage of racism and communal and historical traumas. That was on our agenda prior to what happened with George Floyd and over the summer, the protests around social justice, but it certainly put an exclamation point on our work there. And we created a draft plan working together over those months, and then brought in state agency experts as well to kind of look at what they were working on, how that fit into the plan. And then we put the plan in front of Governor Wolf and the cabinet. It got approval and launched it in July of 2020. The plan itself has three main tiers. The first is state government, again, changing culture, policy, licensing, making it more person-centered. Making sure that we don't re-traumatize people with the services that we provide. The second tier is community-based grassroots movements, again, connecting them together, providing free training and technical support to organizations. So it's not just the organizations with the most money that can go on this journey. And then finally, the third tier is that communal trauma piece. So that's racism and discrimination, disproportionate minority contact, and then natural disasters, crises that communities experience together, like the pandemic or hurricanes or floods or other things that we know leave a lasting psychological mark on the people who survive them. Out of this work, we created HEAL PA, which is a public-private coalition. There's over 120 members within the coalition, some from state government, but the vast majority from different disciplines working throughout the Commonwealth. Not just the physical and behavioral health fields, but construction, for-profit businesses, nonprofits, therapists. We have yoga instructors, mindfulness experts. We have researchers, you name it. And several institutions of higher learning represented throughout this coalition. And then also just last month, the United Way launched a sister effort called Resilient PA, which is a grassroots educational movement that's partnering with HEAL PA. In the easiest way to describe this, within HEAL PA, we've gathered some of the most incredible trauma experts in the Commonwealth. And then Resilient PA, we have the infrastructure of the United Way and all of its partners to get those messages out to people. And so we're really excited about that partnership. So today I want to talk about the causes of trauma and about trauma itself, and kind of dig in to some of the things that Bill and Karen were both talking about. And first, let me say amen to everything that they said about what we should be doing on their teams. I was a CEO of a large social service agency in Lancaster, PA, before I took the job in the governor's office. Had 330 employees who were doing very intense case management and social work with people who were experiencing a lot of traumas themselves. And so my staff invariably was exposed to a lot of secondary or vicarious trauma in working with those folks. And you can have burnout and compassion fatigue. And so I certainly want to help you understand trauma itself, and also what it may be doing in terms of all of our employees, all Pennsylvanians, but especially those who are working in healthcare, who have borne a heavy burden throughout this past year. So trauma is the result of an event or a series of events or a set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening. Another important part of this definition is that depending on the presence of resilience factors, and you heard both Bill and Karen talk about resilience, super important. Trauma can create biologically based responses and can have long-lasting adverse effects on the individual's learning, relationships, functioning, and mental, physical, social, emotional, and spiritual well-being. And really important, not all individuals will experience a potentially traumatic event in the same way. So when you're thinking as an employer, think about all those different areas of well-being and whether or not those are important to the excellence that you're trying to achieve, especially in healthcare, where your decisions mean so much to the people that you serve. Chronic stress, here's another definition. It's prolonged and constant feeling of stress that can negatively affect your health if it goes untreated. It can be caused by everyday pressures of family and work or by traumatic situations. And so think again about that idea of COVID-19, social unrest over social justice issues, political unrest, a storming of the Capitol, all of these different issues that have kind of been overlaid on us in addition to the things we already talked about, right? Your kids are home from school, the childcare issues, all those different overlays were not designed to take that much regular stress. We all have a capacity and a limit for how much we can endure in any given day. And so that's really important to understand that is normal to experience some negative effects of chronic stress when it doesn't go away. In fact, I think there's a moment for potential great empathy right now with the anti-poverty side of my work, in understanding that people that were living below the poverty line were experiencing overlays of chronic stress like this every day of every year prior to COVID-19. And so, for instance, when I talk about adverse childhood experiences, I'm an 8 on the Adverse Childhood Experiences Survey. I'll explain that a little bit in more depth as we go along. My wife is a 0. And so she could sympathize with me, but since COVID-19, she has begun to empathize with me, to understand what those sort of stresses and traumas can do in terms of your daily ability to perform and to be your best. So essentially, it's important to understand that all of us need the same things. All of our brains react the same way when we don't get what we need, and when we experience more stress than we can process. A big important message that I've been trying to get out to people during this past year is, in these kinds of circumstances, it's okay to not be okay. When you're experiencing traumas, when you're experiencing chronic stress, again, we don't ask people what's wrong with them. We ask them what happened to them. And then we start to figure out how we can help them process that. And we'll talk about a lot of those ways this morning. So let's talk about, again, it doesn't really matter. It's not a political issue. There's so much has been politicized these days. You lost your job or you're working from home. Either way, there's additional stresses. Your kids are in school and you're afraid because they're surrounded by so many other people, or your kids are at home online and you've got all these other stresses about doing a work meeting. I had to lock the door in this room to make sure none of my kids walked in this morning because they're all learning online. You lost a loved one, or you think it's all a hoax. Either way, you're feeling stresses around the pandemic itself. You can't visit your parents at home or in a facility. You have comorbidities, or you've already had this and now you're a long hauler and you're having all these extra symptoms. You're afraid of the police, or you're afraid of the protesters. You think one candidate is a criminal or the other candidate is a socialist, or someone's trying to take away your freedoms. These are all stresses. Whether you agree with them or not, people are experiencing them as stresses. You don't feel safe at work, or you want everything to open up because you feel very safe and you're frustrated. All of these, no matter what your perspective is on life, everyone we're encountering is feeling more stresses than they were feeling a little over a year ago, overlaid on all the other things that are going on in the economy and in society. So I would argue that every single Pennsylvanian, every single American is experiencing at least chronic stress right now, if not full-blown trauma. And when you think about people who've lost someone, who haven't been able to mourn properly, all these different issues that are overlaid into this, it makes it one of the most insidious and complex cases of chronic stress, that I've ever seen. So healthcare providers have been hit really hard. And so you've got the primary trauma of separation from your own family. And, that idea of, am I endangering my family when I go home, and not knowing, how much in the early days, and even until just recently, how much the virus can live on surfaces, and how do I keep everyone around me safe while I do my very important work. That chronic stress of feeling in danger and possibly exposed within your workplace, you know, and just going in day after day, shift after shift, and not having that let up. The chronic stress of the workload, you know, and of course I've seen the interviews with providers who, you know, have not been able to take days off, and I think Bill talked about that, you know, the need for trying to help people balance and kind of de-stress, and you can't do that if there isn't a break in that. The secondary trauma of the patient's pain and loss, you know, having to experience that with them, and hearing, you know, of providers who have to hold a, you know, a smart device so that a family can say goodbye to someone, you know, in the hospital. That secondary trauma takes a toll, and it stays with you. And then when you think about, again, everything that's happening outside, so is that healthcare professional a person of color? Are they also experiencing racial trauma and the stresses that are going on, you know, as they see what's happening with George Floyd and others? You know, have they experienced some of those discriminations as well? And has this all put a finer point on it? Overlay the political divisions, and again, it doesn't matter which side of the political divisions. Is that coming in? You know, Bill talked about leaving things at the door when you come into work. I'm paraphrasing, but you know, but those things stay with you. They're pesky, even if you try to leave them at the door. Overlay any financial stresses that a family might be having because of this. You know, is a spouse or partner not able to work in the midst of this, and then any pre-existing traumas or adverse childhood experiences that staff person might have had. And I can tell you that before the pandemic, the Department of Health did a study on adverse childhood experiences and found that 38% of all Pennsylvanians have experienced either physical or emotional child abuse. And so people are walking in, a good percentage of us, with adverse childhood experiences and other complex traumas before they even come in to the workplace. And so all of that is kind of the stew that we're in as we talk about, you know, just how hard and stressful this past year has been. And I want to talk a little bit, if you're not familiar with adverse childhood experiences, just very quickly. Back in the 90s, Kaiser Permanente and the Centers for Disease Control did a study. It actually wasn't about adverse childhood experiences, but they found with actually a very much affluent middle class and upper middle class population, that they saw a disproportionate number of negative health outcomes, not just behavioral health, but also physical health, including things that have nothing to do with behavior, like not just cancers from smoking or from other substance abuse, but cancers that have nothing to do with that at all. Just overall, lots of negative impacts, including 20 years statistically, or on average, 20 years shorter lifespan for people who have 6 or more adverse childhood experiences. And those experiences during childhood were abuse or neglect, and you can see the 5 categories there, and then household dysfunction and the 5 categories within household dysfunction. Interestingly, just recently, just last month, Alaska did a study on preventing the 5 household dysfunction ACEs, and found that if they prevented those starting at pre-birth, that they reduced contact with children and youth services by 43%. So huge impact on lots of other ripple effects and very tragic and expensive interventions for families later on. Philadelphia also did its own ACEs study. They wanted to look at a much more diverse and lower income population, a more urban and more minority-based population. And so these were the results of their studies, and they added 5 ACEs: witnessing violence, feeling discrimination, living in an unsafe neighborhood, experiencing bullying, or living in foster care or other congregate care settings. When we did our work for the trauma-informed PA plan, we also included living in poverty for any extended period of time. There are some important ways to understand the signs of chronic stress, and so the symptoms of chronic stress and trauma: irritability, which can be extreme, fatigue, headaches, difficulty concentrating, or inability to concentrate. I can tell you right now, I am not as good a presenter as I would have been if I did a presentation for you a year ago. It's harder to organize your thoughts. Difficulty sleeping, digestive problems, changes in appetite, feeling helpless, a perceived loss of control, low self-esteem, loss of sexual desire, nervousness, and frequent infections or illness. And so just think about that impact on your workforce and people's ability to be their best when they come to work every day. Again, especially in such an important job as healthcare. Maslow's hierarchy of needs has been with us for a long time. And when I think about Maslow's hierarchy of needs, modern neurobiology has helped us to understand why this is true. But at the bottom of Maslow's hierarchy are those safety issues. And you heard both Bill and Karen talk about trying to reduce fear and uncertainty, right? Those places where you're worried about whether or not you're going to have your basic needs, or you constantly feel insecure, unstable, and you're afraid, that's where scarcity, chronic and toxic stress, and trauma live. And they prevent you from moving up Maslow's hierarchy of needs because your brain is designed to have you focus on those things. So the study of scarcity has shown us that if you don't have enough to eat, your brain won't let you focus on anything else until you do something about that. When I'm talking to an audience that doesn't understand neurobiology, one of the ways I'll explain that is, there's a reason why we're horrible economists when we go grocery shopping while hungry. Our brain won't let us focus. And it's the same for kids who don't get enough to eat when they go into school, and for everyone else. If we don't have what we need, our brains are designed as a survival mechanism to make us focus on that until we solve it. And in fact, in the scarcity studies, the researchers found that people's IQs can go down as much as 10% when they don't have their basic needs met, or they're living in that fear, and they can go back up again by 10% when those needs are met. And so again, think about the impact on workforce to actually have people's IQs lower because of those chronic stresses. The brain, in terms of these chronic stresses, actually treats these stresses the same way that it would abuse and these dangers surrounded with abuse. And so the part of the brain that's in charge of executive function, problem solving, decision making, and emotional regulation, and think about how important those are in a workplace setting, those get shut down by the brainstem, which is where your fight, flight, or freeze response lives. And so it's not something that you're consciously thinking of, but the brain is trying to protect you from whatever that danger is. And that fight, flight, or freeze response is key to how this can be so damaging. And so essentially, it's designed so that if you see a mountain lion, your body's going to flood with adrenaline and cortisol so that you can either fight it or run away or freeze and hope it goes away. But that's a change inside your body chemistry that has real impacts, especially when it's not actually a mountain lion that's the issue. And so fight, flight, or freeze applies to all dangers. And so what happens when that gets triggered over and over again, and your brain becomes hypersensitized to things that might be dangers? One of the best ways that I've heard this described was by Matthew S. Bennett in his book, Connecting Paradigms. And essentially he talks about, imagine you're walking along and you see what you think is a stick. And then when you get up close to it, it turns out to be a poisonous snake and it attacks you. The next time you're walking along and you see a stick, your brain isn't going to wait for you to rationalize whether or not it's a stick or a snake. It's going to take over and shut down that frontal lobe, and it's going to start sending out adrenaline and cortisol to prepare you just in case. Now imagine that every other time for a long period of time that you see a stick, it turns out to actually be a poisonous snake. Well, now your brain becomes super hypersensitized to those shapes and images that it took in before that attack happened. And so you start responding to things that aren't dangerous with that self-preservation response. And that is incredibly disruptive when you're trying to live in polite society, and those aren't real snakes, those aren't real dangers that are in front of you. And so, when we talk about teachers who might be triggering that in their students by standing too close to them, if there's a student who's experiencing abuse at home, when we ask the question, why did that person run from the police when they didn't do anything wrong? There are a lot of reasons why your body might be triggered to that response without you consciously thinking about it. I've experienced it myself, having experienced 8 out of those 10 adverse childhood experiences. And I can tell you, it takes some practice to calm yourself down from that. But there are things that we can do about it. And so how do we heal from trauma and chronic stress? And I think healing is going to be a big part of what we have to do as a Commonwealth, as employers, as families, we have to process what's happened to us this year, and it's not done yet. More things are happening, and we've got to be mindful that we're still in it. And how do we reduce these stresses and traumas in real time? And so I want to kind of close out with talking about that. There are some key things that we can do. And some of them are more involved than others, and some are pretty simple. And you heard some of them already, even in just the presentations about what Bill and Karen have done within their own workplaces. And so you're going to hear some reinforcement around that from the rest of my presentation. And so here they are laid out: breathing, mindfulness, trauma therapy, yoga, Tai Chi, the arts, one stable adult or relationships, and adult capability studies. So I'm going to talk about each of these a little more in depth with the time I have left. So breathing, and that can be just simple breathing, letting your employees know that when they feel these things rising up, it's normal. When they feel adrenaline, their heart starts pumping, something has triggered them. Maybe they see something that reminded them of the passing of a patient that just happened, and they haven't processed it fully. And so they're responding to something that isn't happening again, but something about the environment, the smell, the look. One patient looks like another patient. A patient looks like someone they love. These things can get triggered. And so helping them recognize that, and some simple deep breathing. Another breathing technique is 4-7-8 breathing. And that is breathing in through your nose for a count of 4, holding your breath for a count of 7, and then breathing out through your mouth for a count of 8. And that kind of breathing gives an oxygen boost to your body. It's sort of a signal to your brain that things are okay and that you can calm down. Lowers the heart rate. It can help you relax. People can use it to help fall asleep. So if their mind is racing at night and they're thinking about all these things that happen during the day, focusing on that breathing can help them calm down, especially if they practice enough to really immerse themselves in it, to fall asleep at night. Very important that we get enough sleep, especially when we're experiencing these kinds of stresses. Mindfulness, and here again, not necessarily expensive. There are YouTube videos, there are phone apps. I've done this myself and with my own children to help them calm down. But again, combining that breathing with clearing your mind, letting things go, connecting back to your body and what you're feeling in your body. Sometimes I'll do this in silence with an app that kind of counts me down. And other times I'll do this with music, and that could switch. Sometimes it's classical music, sometimes it's the Beatles. Each person is going to find different pieces of the puzzle to help them calm down and to understand, again, just like no two people respond to trauma in the same way or chronic stress in the same way, no two people are going to respond to these solutions in the same way. And so giving people the freedom to experiment and try a lot of the different options that are out there. Yoga and Tai Chi, again, YouTube has lots of free resources on yoga and Tai Chi. Worksite programs. And again, this is not new. So I was born in 1970. I remember all the hubbub back in the 80s about Japanese business practices and doing calisthenics in the morning. Trust me, if this didn't have a positive effect on productivity, the Japanese wouldn't have been doing it so many decades ago. It still is important that we reconnect with our bodies when our brains are in those states of being hypersensitized, to help us recognize that we're not in that dangerous situation anymore, whether that was a childhood trauma from decades ago that's been triggered, or whether that's something that just happened this morning or last week. Helping our brains recognize, I'm not in that danger right now. That isn't a snake, it's just a stick. And I can breathe and exercise and, again, connect to my physicality so that I can let go of that hyper-aroused state that's trying to protect me. The arts, and here there's some great work that was done after 9/11 with children. Art can be a great tool for helping us process things that we're feeling that we can't put words to. And to help us get that from outside of us and externalize it. And so art, not just targeted art therapy, but just art in general can be a great way for people to let go of stress and to process. One stable adult in relationships, and you heard this, the importance of greeting your staff personally, to connecting as a team, as human beings, so important. One of the most interesting studies I read on this was around wounded veterans in Vietnam. And what they found was that the veterans who were wounded were actually having fewer challenges with PTSD than the veterans who weren't. And as they looked into it, what they found was the veterans who weren't wounded would be in the jungle one day and literally back on Main Street the next day, just flown home. For the veterans who were wounded, and sometimes spending weeks or months in the hospital, they just naturally talked to each other, and they had shared experiences that they could talk through, and it helped them process what happened to them. And so their healing, in many cases, took a different trajectory than those veterans who never got wounded physically, but brought those traumatic and stress wounds home with them without a chance to process it. Formal trauma therapy, and this is a hard one for us as a society. We've been working really hard to try and destigmatize asking for help, and things like telemedicine and being able to talk to a therapist. Our ability through the disaster declaration to waive some of the regulations to allow for telemedicine has actually allowed quite a few people who weren't able to get therapy or didn't have access or felt embarrassed walking into a physical building to reach out and find a therapist. And there are some therapies that are proven as trauma therapies, and I've listed them here: EMDR, TFCBT, TST. I've laid out what they are because it's all an alphabet soup, right? I've done some of these myself and can speak to the ability to let things go. In some cases, things I was holding on to for decades. And you already heard it said EAP. How good is your EAP program? Do your employees feel comfortable using it? And can you help them understand that it's okay to not be okay? That we all have a limit. One of the best ways I've heard it described is if our stress capacity was a cup, we all have a different size cup. But at some point, if there's too much in it before our day starts, then it overflows. And that's every single one of us. That's not a mental illness. That's the brain in its protective capacity trying to protect us from things that are overwhelming. And it gets in the way and actually creates some downward spiral when those things are happening day after day after day. And hope. I was so happy that to see hope in the other presentations as well. We didn't coordinate that, but Harvard has done some great work looking at adult capabilities. Actually, the part of your brain that's in charge of executive function and self-regulation, problem solving, and critical thinking actually doesn't even stop developing until we're 25 or 30 years old. And so there's also some great new research on brain plasticity and the fact that the brain can heal and create new pathways so that you don't have to be stuck in that trauma forever. You can actually help the brain kind of rewire and process things differently through some of these therapies that I just listed to let go of those things that were keeping you trapped, that were keeping you up at night. That other things were triggering. You were home with your kids and something from work came back to you because of something that you heard or you smelled or saw, and it's interrupting your life, it's interrupting your work. And so being able to understand that you can heal. And it may not be the same therapy that works for everybody, but there are options out there to find ways to heal and to get better. There's also for employers, there's something called the Professional Quality of Life Scale that's in our trauma-informed PA plan. And that measures compassion satisfaction and compassion fatigue. And so I have a link here for where you can get it. It's free. It's just a survey that can help you recognize when those employees or yourselves are getting close to compassion fatigue, to burning out. And when we think about how important it is to keep our best employees, who many times are the employees who feel these things so deeply for the people that we serve, how we can help recognize where they are and what resources we can give them if they're starting to feel compassion fatigue before they decide to walk out the door. When we think about fight, flight, or freeze, that shows up in the workplace when we're triggered, right? So we might fight with a supervisor when that's not what we wanted to do, but something triggered us and we're flooded with adrenaline in the moment. And we can't take that back necessarily, right? Or we freeze and we can't do the job. or flight is the worst, right? That's when we quit. Or we get fired, and we intentionally get ourselves fired to get away from the situation that's creating the stress. And so our ability to measure that, head it off, and be preventive, and really, in a lot of ways, it comes back to some things that we talked about but didn't understand just how crucial necessarily that they were. Wellness programs. I think our wellness programs are going to be incredibly crucial to all employers moving forward, especially because of this year. And again, it's not over yet. And so the more we can beef up our wellness programs and be preventive and do a lot of the things that Bill and Karen already talked about, helping employees connect to each other, adding in those things that help us de-stress, talk to each other, process these things, and reduce the fear and the stress in any ways that we can. Taking time off. I know that's hard during a crisis, but that time away is crucial for processing and healing. And so, so those are some key things, or things I do with my own staff. My staff includes the long-term care ombudsman, who has cared for people living in long-term care facilities throughout this crisis. Her team has been incredibly stressed and traumatized by the things that they've endured and the things that they couldn't do to help others during this crisis. And so it's been incredibly important that I lead by example. You've heard that a few times today. And I tell my team that it's important that they take time off. I encourage it. I encourage that they engage in these other practices. And I share with them that I myself have a therapist, and that I have engaged in therapy myself, that it is okay to not be okay, and that we have to focus on what happened to us and not assume that something is wrong with us when we feel this way. And so I will leave it there, and I know we're going to go to questions, so I will stop share and step away from that. Thank you all for your time and attention this morning.
Thank you, Dan. I'm going to welcome back the panelists, Bill, Karen, and Dan. I also want to thank all of you on such wonderful presentations, very informative, and we have a large number of questions. I do want to let people know that if you are attending this presentation, you will receive a survey. So please fill that out. It helps us to create other programs, and also to the Healthcare Connect team, transportation, and those working on our website. We've been doing a lot of hard work as a county. I think Bill talked about that, as we work together so collaboratively in this county, and it's really showing up in so many different and unique ways. So our first question is for both Karen and Bill. As you know, COVID-19 vaccination here in Chester County, the most recent data is telling us that we are 115,000 partially vaccinated and 123,000 fully vaccinated. In terms of vaccination confidence and hesitancy, what are some of the tactics that you're utilizing with your staff or with the community?
I guess I'll go first. One of the things that, and I think, Karen illustrated this the most, is having someone that the person that is skeptical about vaccination can identify with, because if someone is like you, be that racially, be that economically, someone that you can level with as a champion for vaccination, and to ask them, why did you get the vaccination? The best that we know are those that are closest to us. And if you can identify with someone, you're more likely to buy in.
Yeah, Bill, I would absolutely echo that. And I think the other piece too is we found that there were pockets of hesitancy within the work team here as well. And so Dr. Kelly, who I spoke about a little bit about, we would have fireside chats, and we would just have one-on-one conversations. He would just go meet with 5, perhaps EMS team members, or 10 or so. And then they would think about it. And then, they get the first one, and then next, we talk about, first is great, get that booster shot. And so we had a little bit of fun conversation related to that too.
Dan, thank you. Dan, the next question's for you. You spoke about compassion fatigue in long-term care facilities. What are some of the activities or tactics that are being deployed for those frontline workers?
So a lot of what we've been talking about is the same things that I mentioned. So being able to talk honestly and openly in safe spaces about that. understanding that how you feel is okay, and that you can talk about that openly. Working on helping people connect to their EAP programs, and also helping people understand the importance of self-care. That it's so important, and I try to practice it myself because I wasn't so good at it in the early days. We were jumping from one crisis to another. I also now in the last few months have chaired the racial equity subcommittee for vaccinations for the vaccine task force. And so I agree with everything Bill and Karen said, but that's another stressor, and I just found myself doing these, meeting after meeting after meeting, sometimes 7 or 8 virtual meetings in a work day, and being exhausted. And so I've started doing things like sitting in my garden with my wife after work to drink a cup of coffee. Doesn't mean my work day's over, but I'll just, that practice of just listening to the birds and sitting outside, it doesn't have to be something complicated. But if you're feeling like it's becoming overwhelming, again, I can't stress enough how I've told my entire team to move past that stigma and understand that sometimes we all need to talk to a professional when these kinds of things become too much.
Absolutely. This next question is for Karen. Karen, COVID positive employees, how did you manage their return to the workforce?
So we followed the CDC guidelines, Claire, and we also took a look at, through our occupational health team here, active screening. Some would be at home. There would be daily contact by the occupational health team member to that employee, and we would manage the symptoms. So, and try to keep an eye on all those pieces. Some were asymptomatic, many were, particularly if they've been vaccinated, and we still see, like this morning, we do a morning report and I have it in front of me. So yesterday we had 6, today we have 4 out of the team that are still 2 PUIs, 2 positive. So we're tracking them and then do contact tracing. So we reassured them that it was okay. The government was pretty lenient with some leave that I was able to authorize. So that helped because people worry about being out of work, the financial impact of that. So that was a little bit of certainly a game changer that helped as well. Thanks, Claire.
Thank you. And this question is for Bill. Bill, one of our larger employers is asking, as they've done some staff retreats in the past and in person, how do you create team building moments while still abiding by safe practices? Their community health center employs 90 people. Is there anything that you've done in person with a larger group or gathering?
Yeah, it's kind of an unfair question given the nature of the emergency department because we work so close as a team. So I have about 90 employees, but on any given day, 30 of them are probably here. So the fortunate thing for me, and unfortunately I don't have great insight, but about 1/3 of my team is often here in a state of what is normal for us. Which has helped. Zoom can help a little bit to bring people together in that virtual space. Certainly, I don't promote gatherings outside of here because we have to protect our workforce, but I've heard of them and I understand why they happen. So, yeah, I wish I could give more.
No, that's great. Thank you. And Dan, what did you need to change in your approach as a leader during this unprecedented time?
Well, I guess for me, the good news was that, sorry, I'm hearing an echo. Don't know. Did that do it? There we go. So for me, I guess the good news was I was seeing these issues in social services, a couple of decades ago, people burning out, turnover rates, and so it really forced me to double down on things like wellness, leave. Karen mentioned leave and being generous with leave time. Our culture was, you tough it out. You show up for work sick, right? Who wants to take a sick day? I'm saving it for a vacation. So people were coming in sick, right? That worked against us in the beginning of this pandemic because people maybe thought they had the flu and they were showing up and they had something else, right? So those, thinking about not thinking about our leave time as generous, but as strategic and strategically important to keeping our entire workforce well. I think the other thing, as I think about that, that's changed for me as a leader is even thinking about when this is over, flu season. I was struck by the numbers this year on flu seasons. And I think a couple of months ago, I saw the stat that normally that time of year, we've lost 2,000 children to the flu. And this year we literally had lost 2 children to the flu. That means that we got numb to tens of thousands of seniors and thousands of children dying every year from something that we could prevent with practice. And so just rethinking about how we think about those sorts of things every year. And again, really, really emphasizing for my team that for the time that they're with me, I want them here at their best. And when they're not feeling that, I am telling them as an executive director, I am telling them it's an order to take care of yourself, to do something about that, and don't let it show up in the crucial work that you have to do for Pennsylvanians.
Great, thank you. And just any parting words of wisdom from Bill or Karen before we leave?
I promised Flo that I would share one story, and that is early on with the pandemic. It was March 18th for us here. I woke up at home. I thought I had appendicitis. But what did I do? I got ready for work. I came in and I continued to work, knowing that after I got about 3 hours of things done, I would then sign into the hospital for what then ended up being appendicitis. On the OR table at 11:30, I was in my post-op room at 4:30 on a work phone call. And that told me that I was doing this the wrong way very early on. And that if I was thinking that way, my team would think that way, and we would have to think differently. So that was an early lesson learned for me.
So I guess I would just add, Claire, that I get so much more from the team than I know I give, because the team has been gracious with their time, their insights, their opinions, their thoughts, their kudos. And I would suggest that the new gathering for VA has been the vaccine clinics. So I could have 150 volunteers. Most are paid, but they're still volunteering their time on a Saturday or a night to be able to be together. So that has become our kind of new social platform, giving vaccines. So it's okay, for sure.
Great. Well, wonderful. I want to thank again, Bill, Karen, Dan, for your time on behalf of the Chester County Economic Development Council. Mary Kay, any last words?
Yes, I just want to be sure and let everybody know that we found this fascinating today, that the messaging was so important, not only for healthcare, but beyond, and for all Pennsylvanians and anybody else from anywhere else that was actually listening or paying attention. We hope that the students that were invited by Nancy Houghton at the CCIU and the Souderton kids were also feel like, wow, there's a lot going on here, but you're safe and taken care of in terms of people like these who are looking after all of us. So again, thank you all for your time, for your expertise, and onward, everybody.
And we just wanted to make sure they're asking if your slides could be made available, if the panelists would be fine with that. Great, great. So we'll make sure the participants out there get the slides. Thank you again. Hope everyone has a safe and happy day. Thank you.
Take care.
Mhm.